Thank you everyone for joining us again to our cardiac CT and cardiac MRI lecture series here at Montefiore. We have today Dr. Matthew Buddoff. It's a great honor to have him here. As an introduction, Dr. Buddoff is a professor of medicine at UCLA and he's the chair of preventive cardiology at Harvard UCLA. He's in many editorial boards of cardiology journals, including Clinical Cardiology, Journal of Invasive Cardiology, JACC Cardiovascular Interventions, and Cardiovascular Diabetology. He has authored more than 50 books and book chapters and more than 2,000 articles and abstracts. He has received numerous research grants from the NIH, and in addition, he has been recognized for his work by the SCCT with the Gold Medal Award and recently designated as a Master of the SCCT. Today, he'll be talking about coronary calcium scoring and hopefully some data about the EVAPORATE trial. So thank you very much, Dr. Buddoff.
And thank you very much. I'm going to share my screen. Hopefully,
Please do.
you'll see it there.
Perfect.
All right. So I'll take you through coronary calcium scoring, then I'll switch gears a tiny bit and show you some of the final data from EVAPORATE. So, okay. So my disclosures are here. So basically, over the past 2 to 3 decades, we've been using risk stratification tools to try to improve cardiovascular prediction, to identify who might need therapy and who might not. And here's the most recent tool, the pooled risk equation, asks pretty simple questions you're all familiar with: cholesterol, HDL, diabetes, and smoking, and then tries to give you a risk. And the problem is that they tend to grossly overestimate risk. And we'll talk about that and how we can de-risk patients and how the new algorithms of care are moving towards using coronary calcium, not as a way of identifying who needs therapy, but perhaps as a way of identifying patients who may not need aggressive therapy. So this was a study of over 300,000 patients published by Jamal Rama. You can see here in orange is the predicted event rates based on the ACC-HA pooled risk equation. And what you see in blue is what actually happened in the population. So basically, whether they were higher risk on the right or lower risk on the left, it was about a 5-fold overestimation of risk. So when they predicted a 8% 5-year risk, only less than 2% of patients had an event. So it was a gross overestimation of risk. About 80% overestimated. So intermediate risk patients especially get misclassified dramatically with these pooled risk equations. One solution would be not to look at the population-based risk of a patient, but look at the personal or individual risk of the patient. So this is a coronary calcium scan. The coronary calcium concept here on the left. Calcified plaque represents a portion of the total atheroma. You can see that a calcified plaque represents about 20% of all plaque. Fibrotic and lipid-rich plaque represent about 80% of all plaque. And you can see, kind of like the analogy is an iceberg made popular by John Rumberger, where what we see above the surface of the water, when we see calcium on a calcium score, it tells us not only that they have calcified plaque, but that there's stuff lurking below the surface that is even more dangerous. And that's obviously true with an iceberg. When the Titanic was going downstream and it saw an iceberg floating in the water, it didn't say, oh, we should send some divers down below to see if there's any ice below the surface that could rip the hull. It knew what to expect. And you should do the same with coronary calcium. If you have a high coronary calcium score, they have not only a lot of calcified plaque, but they have fibrotic plaque and lipid-rich plaque. And those are the plaques that are probably more vulnerable to cause patients to have cardiovascular events. I'm not going to go through all the data. The data is actually quite extensive. There's probably about 100 prospective studies now of coronary artery calcium. I just want to show you a couple of them because I think they're key in understanding the value and the predictive power of coronary calcium. So this is the St. Francis Heart Study. We're going to talk more about this because they also, as part of this 5,000 person population-based study, embedded within it a 1,000 person randomized trial. But this is the 5,000 person population-based study. And what you can see here is if they had a score of 0, their event rates were very close to 0. And as the calcium score went up, the volume of calcified plaque, that's all a calcium score is just what is the volume of calcified plaque in the arteries. You can see that by the time the score gets to 100, they have an annual event rate of 2% per year. That would be a 20% 10-year risk or a high-risk population. And as the score goes higher and higher, the risk continues to go up, which is what we would expect, a proportional event rate based on the proportionality of atherosclerosis. If we look at the event rates, the relative risk of having coronary calcium above 100, you can see here that based on any event, or on the far right, a hard cardiovascular event, that's MI and sudden cardiac death, you can see about a 10-fold increased risk if the calcium score is above 100. That's very concordant with other studies. This is a study that I published in 25,000 patients looking at all-cause mortality. And again, a score of 0, excellent long-term survival, what we call the power of 0, and we'll revisit that a little bit later. But we can also see as the score goes up in nearly perfect linear fashion, the risk goes up. So by the time patients have a score above 100, they are 10 times more likely to die, just like we saw in the St. Francis trial, and just like we saw in numerous other studies. But I think the ultimate validation of this test came from the multi-ethnic study of atherosclerosis, a National Institutes of Health study that looked at patients who had asymptomatic patients who had no known cardiovascular disease and were followed prospectively. And what you see here is going from a score of 0 on the left, no detectable coronary calcium, very low event rates. And as the score goes up to low, 1 to 100, about a 4-fold increased risk of non-fatal MI or cardiac death. Score above 100, again, that magical 10-fold increased risk. In this study, 10.3-fold. And as the score goes higher, the risk continues to go up. So very proportional. And it was, we followed these patients out for a decade. This is a paper that I published. It looked at different ethnicities, different races, different genders, and different age groups. And they're all about the same. So if we just blow up any one of these different subgroups that we published, this was published in European Heart Journal, 2018. This is 10-year follow-up of the MESA study. And you can see if their score is 0 in the very light gray bar at the bottom, their event rates were very low and they remained low risk for a decade. If their score was mildly elevated, they started to cross that 7.5% risk, that red line. And as you can see, as they approach a score greater than 100 or 300, they become very high risk patients. We've been able to show that if a patient has a score above 300, it's about the same risk as a secondary equivalent. So they're about the same risk as somebody who's already suffered a cardiovascular event. Now, the Walter Reed study looked at also long-term follow-up. This is 24,000 patients followed for 11 years. And you can see that it not only predicted same categories, 0 is in gray, 1 to 100 is in blue, green is 100 to 400, and a high score is above 400 is in red. And you can see, again, a linear relationship, more calcified plaque, more myocardial infarctions, but also more calcified plaque, more stroke, more calcified plaque in the coronaries, more death in the bottom right, and probably most important, panel C, bottom left, major adverse cardiovascular events. You can see the green line crosses 20% event rates. So high risk with a score above 100 and very high risk going off the top of the page with a score above 400. But calcified plaque in the coronaries predicts all types of atherosclerotic cardiovascular disease. Again, a 24,000 person longitudinal study. There's been some attempts to improve the calcium score. This is one where typically we multiply the area times an increasing density to get a higher score. That's how the original scoring system was created by Agatston and Janowitz back in 1989. But since that time, we've realized that perhaps less dense calcified plaque, that the newer lesions are more worrisome. So if you look at panel A on the upper left, you can see a linear relationship as the volume of calcified score goes up. This is also from MESA. As the volume of calcified score goes up, the risk of having an event goes up. Not surprising at all. But if you look on the panel on the right, as the density goes up, the risk goes down. So the worst place to be is to have a lot of volume of calcified plaque and have very low density plaque. And we'll talk more about that when we get to the evaporate trial and different ways of quantifying plaque density. But right now we do not, at least in clinical practice, utilize the density score. But it is an interesting observation that does need more validation. Now we talk about what's called the power of zero, and I think this is an excellent long-term study, 7,000 patients with a calcium score of 0. This was followed up for over a decade, and you can see in patients in blue, the overall population with no family history, 99.6% survival at over 10 years. And if they had a positive family history, a slight incremental risk, but 99.3% negative predictive value. So a very high survival rate if the score is 0. Now, how does it compare to risk factors? And this was a study done by Mike Silverman and Mike Blaha, looking at risk factors and calcium scores together. So first, if you just look across the yellow is calcium score of 0. And whether you had no risk factors on the left or 3 or more risk factors on the right, your risk was very, very low. So a calcium score of 0, regardless of number of risk factors, imparted a low risk score. But look what happens in green. In green bars is a calcium score above 100. On the far left is no coronary calcium. On the right is no risk factors. And on the right are multiple risk factors. And now risk factors play a big role. But regardless of whether patients have any risk factors or not, a calcium score of 100 imparts a higher risk state. So there is some synergy between risk factors and calcium scores, but calcium score is much better predictor of risk than risk factors. And risk factors by themselves, especially in the setting of no coronary calcium, are not predictors of future CV risks. So they went on to do this study looking at all of the different factors over 10 years that should predict a low risk state. So these are supposedly negative risk factors or risk factors that should be protective. So look at the top right, ApoA1. So that's like HDL. A high HDL should be protective, and yet the event rates were quite high in that population. Normal ankle brachial index, no better. No lack of family history, still a high risk state. It's not until you get to the bottom where you see no carotid plaque, where we start to say, okay, there's no plaque in the carotid arteries. That tends to be a lower risk state. And the best place to be is a calcium score of 0 or a calcium score less than 10. So the lowest risk you can make somebody that we know of, looking at multiple biomarkers and multiple other risk factors, is to have a calcium score of 0. And that's more important than a low HSCRP. That's more important than a low LDL or ApoB. And that's more important than a high HDL. Now, when we talk about the potential for improving cardiovascular risk, we use area under the curve or receiver operator curves to try to identify if we can really systematically improve the accuracy of who's going to have an event. So here you can see the blue line is the Framingham risk score. And on the far left, the upper left line, the solid line, is Framingham risk score plus coronary calcium. So everything else really added nominal value, adding C-reactive protein, adding flow of brachial artery reactivity, adding carotid IMT, added very little value. But adding a calcium score to the Framingham risk factor significantly improved the prediction of incident coronary heart disease on the left and incident cardiovascular disease on the right. So we look at this in terms of net reclassification, what actually happened to the patients and how well did the individual tests help us predict. And you can see by far the best, the largest net reclassification occurs with coronary calcium, much larger than with carotid IMT, family history, C-reactive protein, ankle brachial index, or endothelial function, which is measured in the term here of brachial flow-mediated dilation. So calcium scoring by far had the best reclassification of risk. And you can see in all studies published, these are 6 of the largest trials published, prospective studies, but there are many more. All of these studies, the area under the curve significantly improves by taking risk factors and adding coronary artery calcium to the model. So we know that coronary calcium will predict coronary events independent of standard risk factors and more accurately than risk factors in C-reactive protein, but it's also incremental to risk factors. So the concept here, and this is one of the papers that came out just before the guidelines, that said that that quantification of calcium score improves stratification between subjects at high versus low risk for coronary events, indicating that coronary calcium scoring can help match intensity of risk factor modification to plaque burden. So I think that's very important. But this was the first time that I'm aware of where they really started talking about the last sentence, avoiding therapy in subjects with low coronary atherosclerosis that have low 10-year event rates. So now we're starting to talk about the potential of withholding therapy based on a 0 score. Now, I just wanted to show you this one study because I think that while we talk about the use of coronary calcium, and I would say exclusively using it in asymptomatic people, it actually doesn't do a terrible job of predicting risk in symptomatic people. This was the PROMISE trial, and I looked at coronary calcium, and you can see an increasing hazard ratio with anatomical testing in this form using coronary calcium. So coronary calcium did predict cardiovascular events, and the absence of coronary calcium was a much safer place to be than a normal functional test on the right. So what we saw in this study was better risk prediction with coronary calcium and a better way of ruling out disease with a score of 0, not having a future cardiovascular event. In this study, 84% of patients who had major adverse cardiovascular events in the PROMISE trial had abnormal coronary calcium tests. So again, about 5 out of 6 patients were properly identified, whereas only 43% of patients who had major adverse cardiovascular events in the PROMISE trial had an abnormal functional test. 57% of patients who had a normal functional test ended up to go on to have a cardiovascular event. More than half the events occurred in patients with the normal functional tests in PROMISE. So it was a better risk stratifier and predictor of risk, even in a symptomatic population, than exercise treadmill, nuclear testing, or stress echocardiography. If you really want to improve risk stratification and cardiovascular risk assessment, then you add CT angiography to coronary calcium. You now get things like stenosis severity, non-calcified plaque, and a better estimate of plaque burden. And you can see in this study, the blue line is risk factors by itself. The yellow line is risk factors with coronary calcium added. And the orange line is risk factors plus coronary calcium plus information for CT angiography. And they improve the area under the curve from 0.71 to 0.93. That is a huge improvement in cardiovascular risk. Conversely, biomarkers add no value. This was a Framingham Heart Study. This was long-term follow-up, 20-year follow-up in the Framingham Heart Study, and you can see that if you added biomarkers or did not add biomarkers to the Framingham risk, you improved the C statistic or the area under the curve by about 0%. So there was no improvement in prediction either of death on the left or major cardiovascular events on the right by using up to 10 different biomarkers, not only C-reactive protein, but other biomarkers such as NT, proBNP, D-dimer, homocysteine, albumin to creatinine ratio, fibrinogen, and aldosterone. But troponin appears to add significant value to coronary calcium. This was a very interesting study that was just recently published. On the bottom right, the blue line is a calcium score of 0 and a low troponin, a highly sensitive troponin. The red line is a calcium 0 with an elevated troponin. The gray line is an elevated calcium score with a normal troponin. And the worst event rates, the highest event rates by far, were in the blue dashed line, a high calcium score and a high, an elevated high sensitivity troponin. So the combination of troponin biomarkers with coronary calcium does appear to be a very significant predictor. If you just said, well, calcium score or troponin, then calcium score was about 3 times as predictive as troponin. But again, there's synergy here because they're looking at different things. Troponin may be looking at myocardial damage, whereas coronary calcium is looking at atherosclerotic burden. And obviously the combination is not good. Calcium score has been used in a couple other capacities. Just quickly, it predicts heart failure. Not surprising because an elevated plaque burden should be bad for the heart, both for diastolic dysfunction or HFpEF, as well as for systolic dysfunction and ischemic cardiomyopathy or HFrEF. So the net reclassification for heart failure is also present. So a calcium score will predict who's going to develop heart failure in the future. And we don't have to use a dedicated calcium scoring system to derive a calcium score. This was a semi-quantitative method of looking at the calcium score, just saying how bad is it in the vessel, giving each vessel a score of mild, moderate, or severe, and then multiplying that by the number of vessels involved. So you can go from a score of 0, meaning no visible coronary calcium, all the way up to a score of 12, severe calcification in all 4 distributions, left main, LAD, circ, and right coronary. This is from lung scans, ungated studies, and you can see that an elevated calcium score was associated with about a 5-fold increased chance of dying. So again, even in an ungated study, lack of coronary calcium, low event rates, and elevated calcification. When the radiologist sees some calcified plaque in the coronary arteries, it is informative and it is predictive of future events. You can't get an exact score. You can score it, but it's not as accurate because the coronaries are moving, but a semi-quantitative score seems to work well. Interestingly, and of some debate, is how we can use calcium scoring in other subgroups, such as patients with diabetes. Diabetes was recently downgraded from a secondary risk equivalent to part of the risk stratification. You now answer in the ACC-HA pooled risk equation, do they have diabetes or not? So while the cholesterol guidelines still favor treating all patients with diabetes, we're actually supposed to use that as part of our stratification of risk. And not all patients with type 2 diabetes are created equal. This is a study of patients by Dr. Anand looking at type 2 diabetics, asymptomatic, and if they had a score of less than 100, they had perfect 3-year survival. And as their score went up, their risk went up. But look at that, this is diabetics, a calcium score of 101 to 400 had a relative risk of 10.13. Almost exactly what we would have predicted if they were in the non-diabetic population. And if they had a score above 1,000, they were 58 times more likely to suffer a cardiovascular event. More than half of the patients in the trial suffered an event in just 3 years. So some diabetics have no plaque and are very low risk, and some patients with diabetes have a lot of plaque and are very high risk. And I do think in the future, we will be using coronary calcium in patients with type 2 diabetes to help us further risk stratify that group rather than treat all. But right now it's treat all. Another study or another way of looking at the data, this is the area under the curve. You can see the solid line, the Framingham score, the dashed line, the UK-PDS risk stratification, and then coronary calcium, a much better way of stratifying risk in patients with diabetes. No events occurred in this trial with scores of 0. But I think what we want to understand is how to use this test best. And I think this is a nice study to show us. So what I'm going to show you is just from the population-based study called Heinz-Nixdorf recall study, I'm going to show you what happened in the intermediate risk population, those patients with a 10-year estimated risk of 10 to 20%. So they start out intermediate risk, and about 1 out of 7 had a high calcium score and thus was elevated to high risk. So up classification occurs with coronary calcium. And in this study, about one out of 7 people who are intermediate risk were really found not to be intermediate risk, but found to be high risk based on a high calcium score. This is based on true events. This is net reclassification. And if you look at the bigger population, how many people are intermediate risk that do not have any coronary calcium? And the answer is 63%. So when I talked earlier about the overestimation of the ACCHA pooled risk equation by about 70%, this is exactly what we can sort out using coronary calcium. We can identify those patients, those 70% of patients that are not intermediate risk, but are really low risk because they have no coronary calcium. And it's not my suggestion, it's actually part now of our cholesterol guidelines. Another study, again, just showing you that every trial that we look at has a robust net reclassification. This is another study called the Rotterdam Heart Study. 52% of patients got reclassified in that intermediate risk population. Another factor that plays a big role in my practice is using coronary calcium to motivate patients to be better patients. The adage is you can't make an asymptomatic person feel better. We know we can make an asymptomatic person feel worse. So this is the Eisner randomized controlled trial. Over 2,000 patients without known coronary disease randomized to either getting normal clinical evaluation and a nurse visit to discuss risk factors and advise on what the best course of action is based on their traditional evaluation, or randomized to get that same interaction and then a calcium score, and then adjusting the treatment plan based on the presence of coronary calcium. And what happened over the course of the trial, this was the endpoint over 4 years, is that the risk in the patients who did not have a scan went up over time. And the patients who had a calcium score did not have an increase in their overall risk over the 4 years. So what actually happened in their variables? Well, LDL in the no scan group, they still were consulted by a nurse. They were still advised about statin and other therapy. They did see a reduction in their LDL, but it was almost 3 times as great in the calcium score group. Blood pressure went down a little bit in the no scan group, went down about twice as much in the calcium score group. Exercise, new lipid therapies, new blood pressure therapies, new aspirin therapy, all more likely to occur in the presence of a positive calcium score than in the patients who did not get a scan. And lipid adherence was higher over the 4 years if they got a scan versus if they did not get a scan. So it improved risk stratification. But I think the most important data was that it actually saved money. That if you get a calcium score because you're doing less procedures, a score of 0 should not support the use of nuclear testing or stress treadmill or other testing. So they had less tests and they got less medication, and it actually saved money. So coronary calcium score could be cost savings over time. So what about outcome data? Can we really treat based on a calcium score? And the data is a little bit limited because it's old, and then we were told it's unethical to continue to randomize patients with atherosclerosis to placebo. But this was a placebo-controlled trial. So patients had to have coronary calcium. This was from that St. Francis trial. This was the sub-study of a patients, 1,005 patients who got randomized to either 20 milligrams of atorvastatin or placebo and followed for cardiovascular events. And the bottom line is treatment with atorvastatin, if they had an elevated calcium score, but no known risk factor, no known cardiovascular disease, treatment with atorvastatin reduced clinical endpoints by 30% and heart attack and death by 44%. So we can reduce events by treating patients with a statin if they have established coronary calcium. Now, statins are not going to lower the calcium score. They might even slightly increase the calcium score by stabilizing the plaque. It's a very mild effect, and we'll talk about progression in a moment. But the concept here is if patients have an elevated calcium score and you put them on a statin, they have less MI, stroke, cardiovascular death, and revascularization. So back to risk to cost effectiveness. This is again just a study that was done by Phil Greenland and others that looked at the algorithm of treating if they had an elevated calcium score versus treating all patients, an algorithm that's been promoted by some physicians. Just treat everybody with a statin, put it in the water supply, and it is much more cost effective to treat the patients with an elevated calcium score rather than treat all. You can see quality of life and cost per quality of life years gained $18,000 in women and $19,000 in men. If you only treat patients who have an elevated calcium score, it costs about $80,000 per quality of life year if you treat everybody. So this is just a very simple analysis that just talks about taking the average population and improving their cost effectiveness by treating people with elevated calcium. Remember that in population-based studies, and I'll show you from some of the data, about half of all patients have a score of 0. So you will eliminate the need for statins in a large percentage of patients if you use calcium scoring. People often ask me, is there value in repeating the scan? And this was from the MESA study. We did a baseline study. We followed it up at 2.5 years and did another scan, and then followed them for 7.5 years. And what you can see here, after the first 2 scans, we said they are non-progressors in blue. They have minimal calcific progression. Their calcium scores are going up very mildly, like you might see from the effect of a statin in yellow. Both of those groups, very low risk. So if your score is stable, not going up or going up very minimally, you have a very low long-term risk. But opposite that, if you look at the green or the blue or the red lines, if your score is going up a lot, then your risk is very high. So if you continue to lay down calcified plaque, you continue to have increased cardiovascular risk. So I do think there is some value in reassessing patients to identify if they're in one of those groups that are rapidly progressing still in that green, blue, or red groups. And then we can potentially intervene. And we have so many ways of intervening now with atherosclerosis. We have icosapent ethyl, we have PCSK9s, we have bempedoic acid, we have ezetimibe, that we can add a lot from the lipid world to our statin therapy. And if they have diabetes, we can add SGLT2s or GLP1s potentially to further reduce cardiovascular risk. Now, I mentioned before that if we use calcium scoring, it will be more cost effective. And this is really the proof of concept here. This was from the Jupiter criteria. So we looked at the multi-ethnic study of atherosclerosis, and we said, who would qualify for the Jupiter trial? And then we looked at true events. So this was about a 5-year follow-up. You can see of the people who would have qualified, remember Jupiter was a randomized trial of rosuvastatin versus placebo. So in the Jupiter trial, they would have received rosuvastatin 20 milligrams. 47% of patients would have had a calcium score of 0 in that population, and the number needed to treat is 549. You have to treat about 2,500 patient years to prevent one event. Conversely, in the 25% of patients who had a calcium score above 100, the event rates are quite high, and the number needed to treat is only 24. So we can be much more cost effective in adjudicating our statins based upon the calcium score. This is, sorry, I showed this already. This is the concept here of should we treat patients with a calcium score of 0? So this is the Walter Reed study again. This time they said they were on a statin in red or they were not on a statin in blue. And look what happens if you blow up the calcium score of 0 population. There are 2 lines there. Red is being on a statin, that's their event rate. Blue is no statin, and that's their event rate. And this represents almost 9,000 patients followed for a decade. And you can see 0% event reduction if you treat people with a statin for a decade. Now, this is observational data, not randomized trial data, but it's a complete data set because it's done from within the military, and it's long-term follow-up in a very large cohort. And I believe this is exactly what you will see in practice, is if you try to treat patients with a score of 0 with a statin, you will affect essentially 0 event reduction. The number needed to treat with a score of 0 with a statin is infinity, because you get no benefit by taking patients with a score of 0 and putting them on statin therapy for a decade. Conversely, if you look at the bottom left, those patients with scores above 100, red line, patients on a statin, blue line, patients not taking a statin, huge difference. And by 10 years, that difference was 68%. Very consistent with the clinical trial data. If you look at 5-year data, it would have been about a 35% event reduction. And now over 10 years, it goes up to 68% event reduction. And the number needed to treat now goes from infinity to treating patients with a score of 0 to just 12 people if you treat patients who have scores above 100. So huge, huge risk stratification. I think we can use the same algorithms of care for aspirin use. Aspirin on the left, calcium score of 0, whether you're low risk or high risk, you're more likely to have a bleed, that red line, than you are to prevent an event. So when the number needed to treat is above the red line, you are more likely to have a bleed than to prevent an event. On the far right, a calcium score above 100, if you use an aspirin tablet, you're more likely to prevent an MI, 5 times more likely to prevent an MI than to have a GI bleed. So I think we can use calcium scoring to help adjudicate aspirin and statin use. So let me just show you the guidelines, and then we'll go into the evaporate data. These are the 2018 guidelines, and you can see that what they say now, 2A recommendation in intermediate risk or selected borderline risk adults. So that's 5 to 20% risk. That's most adults. If the decision about statin use remains uncertain, it's reasonable to use a calcium score to withhold, postpone, or initiate statin therapy. And if the calcium score is 0, it's reasonable to withhold statin therapy and reassess in 5 to 10 years. If the calcium score is 100 or higher, it's reasonable to initiate statin therapy. So score of 0, no statin for 5 to 10 years. Score above 100, initiate it right away. So where do we use this test? In intermediate risk patients. ASCVD 5 to 20%, risk is uncertain. We put them on it, we use a calcium score. If they have a family history and we don't know if that was transmitted to the children or not, or that was related to dad's lifestyle, we get a calcium score. If they should be on a statin and they're reluctant, or they claim to be intolerant, often a calcium score will help clarify how important it is. And a lot of them will decide to take a statin if they have elevated calcium scores. That's the compliance data. We can maybe think about it for non-statin therapy, for aspirin therapy, and certainly as a motivator. Now, it's not a perfect test in any regard. You want to be very cautious about using it in the age under 40 years old. Those people who tend to have advanced atherosclerosis in their 30s are at maybe have different pathophysiology than normal atherosclerosis, and they tend to have scores of 0. But if they have early onset diabetes or dialysis or FH, you might be able to identify some patients with a positive score and get them on appropriate therapy. We don't want to go from a calcium score to the cath lab. If they are asymptomatic, it's very unlikely they have a high-grade obstruction and the yield will be low. So we think of coronary calcium as atherosclerosis rather than stenosis. So I'll leave you with this concept. Superior doctors prevent the disease. Mediocre doctors treat the disease before it's evident, subclinical atherosclerosis or coronary calcium, and inferior doctors treat the full-blown disease. So I'm just gonna quickly show you my evaporate data, and then I'll open it up for Q&A. This was presented at the European Society of Cardiology meeting virtually about 2 weeks ago. I presented as a late-breaking clinical trial. And the concept of using icosapent ethyl comes from the REDUCE-IT trial, which showed that if you randomized high-risk patients to 4 grams of icosapent ethyl, they had 25% less cardiovascular events. And what we did basically is use the power of cardiac CT angiography, the ability to not only see stenosis severity, but plaque burden at baseline and follow-up, to then quantify using a software to quantify total plaque burden. So not just the calcium score, but now the non-calcified plaque, the low attenuation plaque, and the fibrous plaque, to identify who would progress. Is icosapent ethyl working as an anti-atherosclerotic agent, or is it preventing events through a different mechanism? So we use the same technology to identify in the testosterone trial or the T trial, an NIH-sponsored trial, to show that testosterone repletion in older men promoted rapid atherosclerosis progression. And we saw more non-calcified plaque and total plaque burden by randomizing patients to testosterone as compared to placebo. So we did this evaporate trial to parallel the REDUCE-IT study. We took patients who had the same entry criteria as the REDUCE-IT study, high triglycerides, on a statin, LDL controlled, randomized to 4 grams of icosapent ethyl or placebo, and followed them for 18 months. And basically what we saw was this. In red is placebo. Generally, even though they're on a statin, patients had progression of atherosclerosis over
We're not
time.
seeing your slides, Dr. Buddoff. If you could put the...
Oh, I'm so sorry. I did that. Well, sorry about all that. Let me... Can you see them now? All right, sorry about that. I think you can see them now. Let me just show you the, just one other slide here. Sorry about all that. But anyway, this is our ability to see plaque progression. On the left is a patient with CT angiography. We can see the plaque burden, and we can quantify it through a software device. We can see the population, the type of plaque. In this study, green is fibrofatty and red is necrotic core. It's based on the Hounsfield units or the attenuation of the plaque. The computer then identifies each pixel, each small volume as types of plaque. And on the right, you can see plaque progression. In this patient had progression of atherosclerosis over time. So due to dose reduction with CT angiography, as well as due to better quantification tools, we can now measure multiple plaque characteristics. This was the testosterone trial that I previously mentioned. You can see in blue, the placebo group, in red, the testosterone group. And basically what we see here is progression of atherosclerosis if they're on testosterone as compared to placebo. So we had some proof of concept that we can follow plaque and see changes that are meaningful. This time we saw harm with testosterone. So now the final results of the evaporate trial in red is placebo. You can see plaque progression. Again, these were patients on a statin. They had mild plaque progression over 18 months. And if we add to a statin icosapent ethyl in patients with elevated triglycerides, we generally have a trend towards plaque regression. The low attenuation plaque might be called the necrotic core or the vulnerable plaque. The fibrofatty would be the soft plaque. Fibrous plaque and calcified plaque are fairly self-explanatory. And then total non-calcified plaque is obviously the combination of the three plaques components that are non-calcified, and total plaque is all four of those components. Our primary endpoint was low attenuation plaque because we had icosapent ethyl also has an anti-inflammatory component, and we thought it might be very good at reducing the necrotic core, the inflammatory soft plaque that we see, and it actually had a nice effect. So just to conclude here, compared to placebo, icosapent ethyl, 4 grams a day, significantly reduced multiple plaque components, including vulnerable or low attenuation plaque. There was a very early effect at 9 months, was sustained in increasing significance by 18 months. To the best of our knowledge, it's the first really nice combination, at least with triglycerides and icosapent ethyl, looking at clinical trial results, which reduce it, and then imaging to combine the two to be able to show that we can reduce events and reduce it, and we can improve plaque burden with evaporate. And again, they highlight the early and substantial impact of icosapent ethyl on atherosclerotic burden, and perhaps this is at least one mechanism by which we see benefit with icosapent ethyl in the REDUCE-IT trial. And this was published at EHJ recently. And the interim paper, we had 9-month data that was published in cardiovascular research in July. So that's all I wanted to share with everybody. I'll be glad to open it up for questions or comments. And again, thanks to everybody for joining today and participating.
Thank you very much. That was an amazing lecture, and thank you for the groundbreaking work. So you've given lectures and you talk to many people all over the country, all over the world. And what are your thoughts on why there are differences, regional differences in use and on insurance approval when you compare Texas, California, and other states, and what can we do about it? And please put your other questions on the Q&A and we'll go over them.
Yeah, I see the Q&A, but yeah, so I would say that the biggest problem is that screening tests in general are not easily reimbursed. The insurance companies hate screening tests because they identify some people who need more testing. So I think there's been a very uneven rollout. Texas, by state law, everybody can get a calcium score and it has to be paid for. California, we have fairly good coverage, but it's still not uniform. The regional benefit manager, AIM, our radiology benefit manager, AIM, now said as of January 1st of this year that they will reimburse for calcium score. And they represent Blue Cross Blue Shield and other groups, Anthem. So theoretically, about 40% of Americans are now covered with calcium scoring nationwide, but there's still obviously work to be done with that. So let's read the other questions and answer them.
By VN, is there a role for statin in patients with traditional indications, traditional risk factors like diabetes or high LDL, but with a 0 calcium score?
Yeah, so I am a firm believer that in the power of zero, that if they have no coronary calcium, their event rate over the next 5 to 10 years is very low. So I am very, very, not adamant, but I'm very comfortable if they have a high LDL or they have a family history and their score is zero, of saying you don't need to be treated with a statin right now, let's retest you in a few years. I like to do that in diabetes as well, but the guidelines are so strictly written that diabetics should be on a statin that it poses a bit of a medical legal problem if something unusual were to happen. So I typically treat the diabetics with a statin, but the high LDL or family history or other risk factors, I typically, if they have a score of zero, I will tell them they can forego statin therapy for the next 3 to 5 years, and then we'll test you again. The dose of a radiation dose of a calcium score is about the same as a mammogram, so it's very low. So I wouldn't be worried about the radiation exposure from a calcium score.
A little bit further, what if they have some calcification or plaque in the carotids? Would that make a difference?
Yeah, so, carotid plaque, not carotid IMT thickness. Carotid IMT thickness is probably not a very good test, at least in most hands. It might be a good research tool in the experts, but it's really not a tool that should be rolled out widely. And again, that's not my opinion. That's a class 3, maybe harmful indication by the American College of Cardiology and American Heart Association. But plaque in the carotids is a predictor. So if you do see a plaque in the carotids, I would think about treating that patient. It is a predictor of future events.
Okay, great. From Sala Medicos, they say excellent lecture. Thank you very much. From an anonymous attendee, they say, if an asymptomatic patient has a very high score on a calcium scan, do you reflexively recommend any additional non-invasive diagnostic tests at that point, either functional or CCTA? That's a great question.
Yeah, that's a great question. So I'd say the guidelines favor doing a functional test or an exercise test if they have a very high score. You can sometimes identify patients with severe ischemia, and that might change your algorithm of care. I would say if they're already exercising, if they're truly asymptomatic, I usually don't get additional testing. I just treat them aggressively for atherosclerosis. If they're kind of the patients who just don't move a lot and they don't exercise and they're not testing themselves, then sometimes I will try to get a treadmill or a functional test. Most commonly validated has been a nuclear test after a calcium score. And that is a class 2A recommendation in the guidelines to get if scores above 400 to consider functional testing.
I guess based on your data as well, if you treat them aggressively with medications, you could wait potentially to stress them after treat them for a few months, right? And seeing.
Sure. Yeah, you can definitely, there's no rush there if they're asymptomatic for sure.
Okay, next question from Carlos Dumont. What is your opinion to routine use of CT angio in patients with a previous CABG?
So I love CT angiography after CABG because it can show me the graphs, it can show me where the graphs are, it shows me which graphs are patent. So I think it's a very robust tool post-CABG. It's so hard sometimes for us. I'm an invasive cardiologist. It's hard to take people to the cath lab who have prior CABG if you don't have their CABG report or if you don't have a prior cath to go on, because you don't know where the graft origins are and you don't know how many grafts there are. So to have a roadmap with a CT angiogram is robust and very useful. And I would say it will become fairly routine. And if all the grafts are open by CT angiography, then they probably don't need a cath. So I think it's going to be a standard of care use.
Next one, is there any evidence supporting reporting calcium score broken down by vessel?
Yeah, so the data is not as robust. We've been trying to answer that question forever. I thought left main and LAD calcium would be more predictive than circ and right calcium, but it's probably not quite that easy because when you look at especially the left anterior descending, we lump together proximal, mid, and distal calcium and diagonal branch calcifications and put it all as LAD. So just by vessel, it's not that improvement, doesn't improve prediction that much. Left main does a little bit. but the others don't really add that much value. We're trying to look at it per segment now. On a calcium score, it's a little bit harder to do because you have to then segment the coronaries, but we're trying to do it per segment, and we'll get some data out of the MESA trial shortly. It's an R01 that we have to look at that specific question, but I don't have the data yet.
Great. Next one, are there gender differences in predictive value of CAC in detecting some clinical disease? They're asking particularly in women with diabetes and ages 45 to 50.
Yeah, I mean, women women have later onset of coronary calcium. It's about a 10-year lag, as you would expect, based on the clinical events, but they actually are just as good at predicting events. So if a woman has coronary calcium, it's just as bad as if a male has coronary calcium. They're actually, the risk prediction is almost identical based on gender, age, and race, ethnicity. That was my paper in European Heart Journal. It just said plaque in the coronaries is bad, lack of plaque in the coronaries is good, a score of 0, and it doesn't matter who you are or how old you are or what you look like.
That's great. I think probably in populations that also are more at risk with less socioeconomical status, calcium score, if they're going to use their money for copays, they may as well use it when they provides more benefit, right? What do you think?
Absolutely. Yeah, no, I think that's a great observation.
Next question from Jeremy about using CTA in asymptomatic patients. Which patients would you use it on, and if there's any value?
Yeah, I mean, some people love this concept of CT angiography and as a screening test. It gives you more information. Jim Min just gave a brilliant talk at the American Society of Preventive Cardiology meeting about a month ago, showing that CT angiography in an asymptomatic population is robust. The problem is that that's even a more expensive test and a more complicated test, and it's further not reimbursed. So you have less data and more cost and risk. So I don't see that becoming an algorithm of care, at least paid for, in the foreseeable future. If you were going to use CTA, I would use it in age under 40. So if you were worried about a young person with athero, let's say severe family history, or early onset type 2 diabetes, or familial hyperlipidemia, you probably have to use a CT angio instead of a calcium score. You need that young, because calcium score doesn't work very well in the young.
The next question is, how do you treat when a diabetic patient has a CAC less than 100?
Yes, I would say with diabetes, any coronary calcium is bad. So I really believe in the power of 0. If their score is 0, I think they're relatively protected and I would be less aggressive. If they have some athero, I would say they're a diabetic with atherosclerosis, and I would start treating them more aggressively. The higher the score, the more aggressive treatment I would go. And again, we have icosapent ethyl well studied in diabetics. We have PCSK9s. We have other therapies like rivaroxaban, and even now indications for Brilinta with asymptomatic people at increased risk. So I think that there's going to be a dozen ways of treating patients to add to statins if you think they're at high risk. So if you find a high score in an asymptomatic person, there's a lot of options now.
That's great. From Dr. Borsheimer then he says, thank you for the informative lecture. And he's asking about generic Vascepa. Do you think there's any difference or any concerns for generic Vascepa versus the brand?
Yeah, so it's not available yet. I'm not sure it will become available. There was a lawsuit that Amarin lost to protect Vascepa from becoming generic. So theoretically, generic companies can make Vascepa, but I have a feeling that because the market is so small that they will not start making generic Vascepa in the near future. So I think we're going to be using Vascepa for the next few years. We'll have to see what happens with that.
Yes, a few more questions. So what about patients that have a calcium score but actually have soft plaque with severe disease? Have you come across with any of these patients, and what's the percentage?
Yeah, so it's low. The calcium score is effective at ruling out disease at least with 95% confidence, but that does mean that about 5% of people can have some plaque. But of those 5%, most have very mild plaque. So I would say it's probably less than 1% of patients have severe atherosclerosis with a score of 0. So I'd say it's rare, and I wouldn't worry that much about it in general. Now, again, FH, young people who have weird, pro-thrombotic diseases or pro-atherosclerotic diseases like severe family histories, that might be the exceptions to that rule.
Okay, great. And do you report density, or do you think people should report density, and does it affect the risk and treatment, like you mentioned briefly?
Yeah, I'm not a big fan of density, to be honest. I was on that paper with Mike Cricky. I think it's very provocative. I think it's too early to understand the use and how we can incorporate density in our algorithms of care. So we don't report it.
Okay, great. And I think just to finish, what is the criteria to differentiate on basis of density between vulnerable and stable plaque?
Yeah, so for us, we used vulnerable plaque was Hounsfield units or attenuation of -50 to +50. And anything more than 50 is stable plaque, fibrofatty or fibrous plaque or calcified plaque. So these are just cut points that have been validated with intravascular ultrasound. And the lower the number, the more pure necrotic core it is, the more negative it is, the more necrotic core and pure fat it is. And we think that that's more vulnerable.
Okay, and I see one last one from Juan Terre, one of our interventionalists. It's great that he's here as well. Any recent data, he says, on PCSK9 inhibitors and plaque reduction?
Yep, so we have the Galagoff trial that looked at PCSK9s and plaque reduction that used intravascular ultrasound. So the lower the LDL, the better the plaque regression. We don't have CT angio data yet, but Dan Berman at Cedars-Sinai is doing is doing a study. He had an acronym, I forgot the name of it, but he is doing a trial using Repatha with CT angiography to show regression of atherosclerosis, and see if we can see that with CT angiography. So that trial is still ongoing.
That's great. Any ongoing with the diabetes medication, you think, GLP?
Yeah, so I'm doing a trial called STOP, which is with semaglutide. So we're using a GLP-1 receptor agonist to look at plaque progression versus placebo, just like evaporate, but we're using semaglutide versus placebo instead of icosapent-ethyl. That trial is about 2/3 finished, and hopefully we might hit late breaking for ACC, if not probably ESC next year.
That's great, very exciting. Okay, great lecture. Thank you very much for your time.
It's a pleasure. Thank you guys so much, and best of luck to everybody.
Okay, bye-bye, take care.
Take care.